Hi. Hi, Amy.
Hi, Kristen.
I'm Kristen Piscucci with Birth Monopoly, and I'm here with Amy Gilliland, PhD, to talk about her new article, Birth Rape and the Doula. I'm warning you that you will probably hear children in the background at some point, and there's nothing I can do about that. Hi, Amy. Can you give us a little bit of information on your background and your work?
Sure. I started out as a doula back in my early 20s. And before DONA was even formed, we had our own local organizations here. And so I became a part of the DONA board during my formative years and then became a doula trainer about 18 years ago. I've done almost 90 doula trainings at this point. And when I decided to go to graduate school, I took 10 years to get my master's and my doctorate degree. So now I'm officially called Dr. Gilliland. And I did that studying birth doulas. And so I've interviewed 60 birth doulas, nurses who work with doulas, parents who've had care, both mothers and mothers and fathers together, because you get different interview data that way.
Uh-huh.
And who had both care from doulas that they hired and also care from hospital-based doulas. And out of that, I've published, between that study and several other studies, I've got, I think, 7 or 8 publications in peer-reviewed journals, chapters in 3 other people's books. And I have a blog called Douling the Doula to kind of pass along what I've learned, because all of those doulas I interviewed all live in my head. So
Yeah.
I speak
Yeah.
frequently at conferences. And so my forte is kind of taking research and making it applicable and squeezing what we can out of it and making it real and useful, whether that
Yay.
audience is doulas or doula trainers or nurses and physicians. I serve on my county's FEMR, so reviewing death records and that have happened in the previous quarter. And I'm also on the board of directors of the Wisconsin Association for Perinatal Care, which means I get to listen in on a lot of conversations about the concerns of physicians and nurses and figure out how do we make change, because that's why I'm in this game. That's why I've always been in this game.
It's a two-way conversation, right?
30 years ago. What? Yeah. So that's why I'm happy to talk to you today, because we all want to make change and we all have to do it in different ways, because if not everybody's coming at it from different directions, we're not going to get it.
I think you and I have chatted about this before, about how, in a lot of ways, like the conversation has been very us and them, for good reasons. I'm not blaming anyone for this. I'm just saying, I think it's, we're moving that conversation forward a little bit, as birth advocates and birth professionals and birth workers. We've got to be realistic about the people we're working with, right? And they are people. They're not bad guys, and they're not, like this giant evil system. They're human beings, and they're bringing a whole bunch of, their own experiences and perspectives and backgrounds and trauma, which is something that we really need to talk about. And none of this excuses any of the bad behavior or the bad attitudes, but it helps explain it. And we're not going to fix it if we don't understand all these aspects. So, there's really no point in pretending like, it's either, it's very black and white, because it's really not black and white.
Part of having the perspective of years, of decades of being in this woman's army, as I've heard people refer to it as, is that I'm able to look at problems in a variety of ways. And then through my academic training to also kind of say, okay, what's really going on here? And what is wrong with the system? And when you're looking at, okay, how is interpersonal violence perpetrated on the laboring person? Okay, because that's what I'm talking about in this blog post. And I'm just like, well, what part makes that acceptable? How do we get, when I started expanding around the problem, I said, well, how do we get to a place where that's acceptable behavior? How do we get to a place where people are
where specifically what is acceptable?
Well, when we have, as I described in the blog post, about when we have a medical care provider who is disregarding the mother's exclamations when she's saying no, when she's saying stop, and they're continuing to do that, and there's an incredible amount of distress and emotion around it. And the
Yeah.
doula is like, wait, I'm witnessing this. What is this, what I'm seeing? And this is freaking me out. And I don't know what the heck to do. I don't want to just stand by and be complicit with it, but I'm not prepared to deal with this particular situation. So what I'm saying is that when I expanded around that and looked at, well, what makes that okay for that care provider to be acting in that particular way? And what makes it okay for the other staff people in the room to tolerate that? What have they gone through that got them to that place?
Well, where it's okay in their own minds. Not that it's an okay thing, but
no,
in
but
their mind,
yeah, I'm elaborating on what you have said, and also talking about it with care providers, because that's the other piece, is that I have gone up to doctors and nurses whose ears I have and say, look, when this happens, and I've never, ever, ever gotten an argument that it didn't happen. Okay. No nurse or physician has ever said, oh, that doesn't happen. Nobody's ever denied it. Okay. So, and so it means that within that system of training, you know, now we have medical students who've been making really, really good comic strips about the way that they are demeaned, about the way that their supervisors and the physicians who are training them treat them. And in fact, I think Johns Hopkins, who I referenced, said that they said we have to make a systematic change because this is not okay, where our system of education is based upon demeaning those who have less power than us. It was like, if that's the system you've been trained in for a dozen years, it makes perfect sense for you to treat your patients that way, to pass that idea along, because of course it happens unconsciously. But I think that when we talk,
it's just it's your operating system, right?
Yeah. When you train to tolerate interpersonal violence, you don't recognize it in yourself, and it's okay for it to occur until you like have this wake up moment. And you go, wait, what's really going on here? And I don't think that doulas in the moment at the birth can address that. I think that it needs to be addressed, because when we have good physicians committing suicide and we have high rates of depression and mental health issues in our medical care providers and nurses and doctors, that to me is a part of the same systemic problem.
Yeah, totally.
Yeah. And so it's like, I think to me, the most significant place, and the place where it needs to stop first, is how medical care providers interact with patients. Oh, you betcha. I think that is the place. But where that behavior comes from, I think comes from the life experiences, but also the socialization experience of becoming a medical care provider. What does that culture teach people is okay?
Well, and so many of them describe it as abusive. I mean, that's that's widely acknowledged that a lot of medical training is abusive on the trainees. So yeah, it seems like you're starting from a pretty shaky foundation right off the bat, huh?
Well, I think what that does is it gives me some background. It's like it says to me as the doula, it was like the first couple times I was asked, what do I do? Which started 20 years ago. You know, it was, well, we would be at cesarean prevention movement meetings, which was the precursor to ICANN. And that was like our activist component thing. And we go, well, what do we do when this happens? What do we, this is not news. This is not new stuff. It's been trying to figure out in the beginning. You got to realize up to about 2000, we were still worried about getting thrown out. We didn't have right. We didn't, as doulas. Yeah. We didn't have that right to be there. We were kind of in that, well, you're not family.
Yeah.
So there were a lot of us that were not in that. You had to earn that right on an individual basis in a lot of places. So the ability to be able to speak up in this way, it has been earned by all the doulas that came before.
Yeah, I think that's important for doulas, for doulas who have been around for a long time, who are watching things change, and then for newer doulas who may not understand why things are the way they are today. Yeah, because there is this history that doulas are also trained in a certain way and have been sort of historically. And one of those things, that I've that I've heard here and there is the idea of you're not supposed to talk to the provider, which is like mind blowing to me. You know, like I can't imagine a more disempowering principle as a professional. You know, and for the mother to think that the person she hired is not allowed to talk to the other person she hired, and you know, for so many reasons, I think that's really problematic.
I know exactly where that comes from, because I interview doulas, and I had several who said, no, my thing is I just show up and I take care of the mom and I do those comfort measures, but I'm there to urge her to talk to her care provider, but not for me to do that addressing. And I also think that trainers who have taught their doulas that are thinking, well, they're not very skilled as communicators. So I'm not going to try and teach them how to do that because I can't do that. So I'm that being quiet and doing all this emotional support and physical support and giving them information, that's good enough.
Which would be good enough, right? If we were in an ideal system.
Yeah.
It would be.
Yeah, I think it might be. Well, that was also a preservation tactic, because they were in environments that were very, very doula unfriendly. So in order to do your doula thing, in order to support and help these women have unmedicated births, because that was also the subtext of it, you got to see. It was, in order to do that, I need to be quiet and unobtrusive and not get in the way of the medical people. So I think there's a history to where that comes from. I've never taught that. I've taught communication skills because background. I have a degree in communication. I studied it for my first master's that I left unfinished because the men in my master's department didn't believe that women should get master's degrees or doctorates because we were just going to leave and have babies. So it sounds funny now, but we dealt with that level of discrimination on a daily basis as female graduate students here in Wisconsin in the early 80s. And I come from Northern California. So I come from the beginning of everything. And the idea about questioning and communication and human potential, those are all things I was raised with. I have a different mindset than this Western one that I live in. So, which has pluses and minuses. But to get back to this idea about not speaking and can you still accompany someone and still have power and help? Yes, you certainly can. And but when it comes to what we're talking about, if your voice hasn't been in since the beginning, that's a very tricky time to speak up. So you need to start when you first arrive in the room and introduce yourself. So I've always aired on this is how you communicate, and I spent hours on that. How to talk.
Yeah, and on that note, can you just really quickly kind of breeze through those 5 steps that you outlined in your in the Birth, Rape, and the Doula blog post? Well, I still want people to read the article, of course.
Yeah, I think that what the principles are is that the mother, for whatever reason, isn't being heard. And she may not be making noise. She may be squirming and trying to get away and turning her head and using a lot of nonverbal behaviors that are showing distress.
As the provider is
doing whatever they're doing that she's objectioning to.
They're having asked permission for, or
there's a lot of those things, especially when they're happening in the immediate postpartum period, that are like, well, she's got the baby now, she's not paying attention to me, and whether the baby's on the mother or in the warmer, sometimes it's happening earlier in labor before the baby's been born. I mean, there's certainly different situations, but the thing is that she's not being heard.
Right.
And our role is to amplify those things. I don't see it as a contradiction at all in the conventionally accepted doula standards of practice. It's not at all. It's just like, oh, they're missing this. Here, let me bring this to your attention because you're busy with your own thing. That's why so I start with this initial assumption about they're just screening out the mom because they're concentrating on what they're doing. I try to start with that place of forgiveness rather than that place of, they're all misogynist women haters, I try to reserve that. That's like way down the line for me to come to that conclusion. But initially, so I'm thinking, they're not hearing her. So the first thing you need to do as a doula is to say, oh, did you notice? So Dr. X, um, uh, all my moms are either are Nora or Jane, so it's just easier that way. So I said, oh, you know, Dr. X, Nora's writhing on the bed. Did you notice that? Nora, did you want the physician to stop or pause? Because it's got to come out of her mouth. So
Right.
I can say that, oh, I'm noticing this. So if she's being verbal, then you can say, I heard her say stop. I heard her say no. Did you also hear that? And once I've said it, it's kind of like you can't ignore it anymore. You've kind of put in that point of like, they have to make a decision. Am I going to ignore the doula too? Or am I going to go on? And if the care provider is doing something, then the nurse, even if the nurse is over by the warmer, is over in the ante room, I'm going to call her back. So, and if we have an established rapport, we've been together for a few hours, or maybe sometimes it's just an hour if you've had a shift change right at the time of birth, it's, or any time really, but to say, get that person involved, because nurses are often more in tune with what's going on with the patient. And I use their language, not my own, because they want to be in tune with their patient. If they're in a system that allows them that grace, not all do, especially busier hospitals. But what we want to do is we want to bring it to their attention. So that is in all of those first several steps, is that's what I'm trying to do, is to just say, hey, I'm noticing this. Are you noticing this? What are you going to do about it? So, and then getting the mother to articulate, yes, I want you to stop. And then if the care provider does, you really need to give them gratitude instead of saying, well, this is what I expect. But it's like, in their minds, often, I just need to get through this. It's not going to take very long. If we just get it done, then it's over with, and then she can go back to being with her baby, rather than realizing that the outcome of not listening, the outcome of continuing to do whatever you're doing, is going to have a much greater negative impact. And that is the point of blindness that care providers don't see. They don't have, they're not schooled in trauma-informed care, as Amy, oh, you know her last name better than me.
Meister Stetson?
Yes, that's it. Yes, Amy Meister Stetson wrote in her article in the Squat Journal last November that was so about trauma-informed maternity care. Yeah. And I just did a session last week at a conference for physicians and nurses where I had almost 200 of them there, and I only had 20 minutes to talk about trauma, how to prevent birth trauma, but they ate it up. They really did. I gave them 5 actionable behaviors that they could do, and they really were hungry for this. They wanted to know this. They wanted to understand, who is this client to me, a client to them, a patient who comes in with this long birth plan, you know, and she's not going to get any of it. Who is this client who comes in trying to control everything? I said, this is the client who's been traumatized. This is the one who, you shouldn't be joking about her. And back at the nurse's station, you need to be saying, oh, this is a woman who needs greater concern and attention because she may have mental health issues, and not to be ashamed of that. Because as women, almost, if you make it through your life without being assaulted or experiencing interpersonal violence, that's rare, you know?
Well, yeah. And I think it's interesting. You know, obviously, I think that the idea of trauma-informed care needs to just be the standard. It's disturbing to me when people make the assumption that this is only traumatizing to this woman because she's been traumatized in the past, when these things could be very traumatizing for anyone who's never had any sort of trauma in their past. Like, they can be traumatizing all on their own. For someone who also has been traumatized in the past, it can be a million times more traumatizing. So it's not, you know, you don't have to be a rocket scientist to figure out that it could be traumatizing for anyone to have something inserted in their body against their will, right? I mean, it's not, you know, but like you said before, you know, of course, it should just be the standard, but, you know, that's why we're doing this work, right? So we can get it to be more of the standard and kind of bridge these gaps.
What I have found is that over the years in trying to change from within the system, because I did an assessment about 15 years ago about, well, where's my gifts? You know, where are my gifts? It's like, I can talk in a way that medical people will listen. So how can I approach them in a way that's going to encourage change? And so that's the way in, is to talk about people who've been traumatized before, not about how you're going to traumatize the person who's never been traumatized if you continue to do this. That's so frightening and scary for them that it's going to send the denial triggers up. Oh no, you know, and the distance is put up.
You're right. It is about that.
It's figuring out, you know, with trying to get system change, systems are made up of individuals, but yet those individuals have to feel safe where they're at and then be able to be sincerely curious about doing things another way. And if people are defensive, they're just gonna get stuck in their positions, you know. But it's like, not saying that what they're doing is acceptable, but accepting the status quo. There's a difference between those two things, you know. Accepting, well, that's the way things are now. And then helping them to be curious about, well, why would I want to change? I mean, we think about lowering the cesarean rate. I go back to what Michael Klein did with the episiotomy rate when he took, you've talked about that study before too. Well, briefly for people who don't know. He posted anonymously the episiotomy rates for everybody in his hospital in British Columbia. And then the physicians who had very high episiotomy rates looked at the physicians who had low episiotomy rates and said, well, how do they do that? How does the baby come out if you don't cut her and stitch her up? How do you do that? And so, because he did it in a way that made them feel safe to be curious. And to me, that's been a real model, whether I'm in one hospital making repeated visits, doing workshops there to help them to change their whole climate of their unit, which I've been done. But that feeling, that principle of safety in order to be curious has served me really well. There's other paradigms as well, of course. But when we get back to birth rape and people asking me, well, does this stuff work? Because that says, well, will this work? I don't know. You have to tell me. But I don't see why it wouldn't.
Well, I mean, it's like what your experience has been with it.
But I'm almost 6 feet tall. I'm white. I know how to speak their language. Now, they have no idea I have a doctorate degree. All my shirt says is my name, and then it says certified doula. I don't use any alphabet soup, nothing. They don't need to know I'm affiliated with the Center for Family Wellbeing. They don't need to know any of that stuff. They just want to know, well, what's your name and what's your role in the room? So for me, it's worked well because I've tried to develop a rapport. When I was a newer doula, I would say that in those instances, there were times I did things wrong and as humans, we all learn by trial and error. And me freaking out didn't help. I've done that. I've gone like, oh, what are you doing? She doesn't like that. I've been that doula. Years ago, I've been that doula. What are you doing?
The bad doula? The rogue doula?
No, didn't work out well. The mother was happy, but nobody else was. And so I didn't consider that to be a real positive outcome. But when I have said, I'm noticing this, do you notice?
Well, I consider that to be a positive outcome. Yeah. Just not a good long-term solution.
Probably that. And probably that.
Well, I'm always plugging Mastering Respectful Confrontation by Joe Weston. I do not get any sort of kickback from Joe Weston from talking about this book, but I think that's something that every doula should, especially newer doulas, should be completely familiar with, because, like you said, it's different for different people. These really are communication skills. It's not about having, a little script that everybody has the same script and it works the same for everyone in every situation at all times. It's about having skills that you can tap into, no matter what the situation is. And
And
so I just want to once again recommend Mastering Respectful Confrontation by Joe Weston.
Right. And I haven't used that book, but I've used a lot of negotiating books. I do a 2, 3, or 4 hour workshop on communication skills for birth professionals. The first 2 hours
Awesome.
listening. The second hour is internal preparations to communicate effectively, the things you can do yourself. And the last hour is on negotiating and handling confrontation. So
crucial. They're totally crucial skills.
Right. And so
I don't know how you could be a doula without it.
An effective doula. And those are things that you can't teach in a 3-day beginning doula training. I can say, okay, here's how you get along with care providers. Here's how you make suggestions. Here's how you, here are things that you're going to be able to do that they're not going to be able to do. And you need to respect that they're going to be touchy about the fact this. So I try to give people an all around good beginning focus on that. But in this particular instance, I think you want to start out with amplifying your client's voice as much as possible and to get the care providers listening to their patient again, and connecting with their patient, because that's the thing, is that there's a disconnect and they're not noticing or not seeing. And so you want to try and make, hey, no, here, look at this. Do you see, look at this thing happening here. Okay. And I see it. You need to look at this. And so bringing their attention to it. And there's going to be some instances, like I finished reading Kiara Bridges' book, Reproducing Race. And if I was an African-American doula in a big institution like that, where my client is also African-American and she's been taken care of by white staff, you bet I'm going to use a totally different sense of, I'm going to use a totally different, what's the word I'm looking for? Selection of survival skills that I know from being in that culture and having to interact with white people in power. And so for that doula, she may go directly to number 5, or she may know and be able to assess the situation and say, I'm going to start with number 1. But those situations are going to vary. And for indigenous women as well, sometimes the situations they're in, with advocates and outcomes, and you don't want to put yourself in a place where the care provider is going to accuse you of child abuse and neglect, and you're going to have to be dealing with social services, because these are things that people have said, and you know that very well in Improving Birth. You've got a whole list of consequences when people didn't follow, weren't compliant about things that happened to them legally and in many other ways. So I don't have a closed eye towards that, and the doula who's in the situation is going to have to really assess that and take her cues from the mother and what the mother wants her to do.
Yeah, I mean, that's always one of the risks is punitive treatment. Anytime you're doing anything other than complete compliance, is but that's why, of course, why these skills are so important to bring people together, right? Instead of automatically going towards some sort of antagonistic, just, hey, stop what you're doing. Right? Because there are a million other options out there other than stop what you're doing right now. Although I'm not going to sit here and say that I don't think that would be appropriate in certain situations. And
there's some care providers who are tired and don't notice. There's some care providers who don't like the patient. There's some care providers who, don't like what the patient represents in their worldview. So you've got all the symbolic meaning of this particular person. So there's, and care providers as human beings, pulling a power over thing in the moment, or they're tired and they're not paying attention. There's a whole myriad of reasons that people do what they do.
I think of several doctors. I don't know of any nurses. That just means that I personally don't know of any. But I think of several doctors who have had really surprised reactions to women afterwards saying that was completely traumatizing when whatever, and the doctor being like, "What do you, that you were bothered?" Like, I didn't realize you were bothered in the moment. No one has ever told me before that this would be a problem for them. Like they've never gotten feedback, apparently, like right to their face, that this was a problem, that when I said no to a vaginal exam, I really meant no. I didn't mean you just go ahead and do it anyway while I'm incapacitated with a contraction or something. And they're like genuinely surprised that the woman was really bothered by it, and seemed to think that like she's, no other woman has ever been bothered by it before, because no one actually said it right to them, I guess. Like they needed to actually have it said to them, which I think is probably the best premise to act from, rather than making any other assumptions. When you're trying to communicate with someone, is let's just say this person is ignorant, rather than this person is being, is being just a horrible person, is being, malicious or intentionally, whatever. Yeah. And I think it makes it a lot easier to speak, keep things on a respectful level when you can, just give them a little bit of grace that they're doing something out of ignorance that needs to be corrected, as opposed to maliciousness or malice. Yeah. Hey, Amy, the term birth rape is super controversial.
Yep.
I wanted to talk about your definition of it a little bit, because I think that might be helpful to some people who, I remember when I first heard the term, I thought that's crazy.
Yeah.
Like, how dare someone use that? How insulting to rape victims or rape survivors. And then I learned more about it and I changed my mind. So can you talk a little bit about the definition that you, put in there for us?
Sure. I as a qualitative researcher, one of our ethical principles is that the people who are having the experience get to define the experience. So for me, when I asked people who had been through this, and several of them had also had experienced sexual assault or rape, and they said, no, it was really the same thing. There was nobody who said, I experienced both and they were qualitatively different. They're the ones that show.
I've had the same experience.
Yeah.
I mean, that was sort of what gave me permission to start, okay, maybe this is a term, was having rape survivors say, I was birth raped. Yeah.
And once rape survivors who have not had the experience of birth rape, once they hear about it, most often they're like, oh yeah, I can see the allegories there between the two experiences and why someone who'd been through that. But I feel like using the term assault during labor is like, well, I put some butter on my toast. Oh, I was assaulted during my labor. It doesn't have that zing. And I think that's why people use that term, because they want people to get the notion that, no, this wasn't just
how violating it was.
This wasn't something that can be passed over. This is something that was a huge, big moment in my life. This was a defining experience for me that altered who I am fundamentally as a person and altered my life from here on out and how I approach these different experiences. I mean, when somebody says, no, I was fundamentally changed by this.
Yeah.
And
I've spoken to so many women who say that, who are like, I was a different person before and after birth, and not because of the baby, but because of how I was treated in my labor. I think of, so many of the women we interviewed with the Exposing the Silence Project who are now on or have been on medication and seeing mental health providers, that they never had any issues prior to birth. I mean, it has literally altered the course of their life.
And as a sexologist, that's one thing I didn't mention. I'm also an ASEX certified sexuality educator, and that's the highest level of certification you can get in the world. That for me as a sexologist, because I published research on that too, on women's experiences, that we don't talk about the sexual consequences of birth either.
Yeah. Oh, that's another that's another conversation.
That's a whole nother conversation. Really that's that thing about, oh, it's the baby. No, 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 no. It's what you went through during the birth and what your partner went through. If your sexual partner was also there and present and watching, saw how you were treated, there's all this processing and recategorizing and cognitive appraisal. How do you think about this? There's all this stuff that has to occur, and people think they're just going to be able to pick up the threads of their sexual life the same way they were before. Some people do, but and it's not always, you're not always out of the woods simply because you had a home birth either. People think, oh, well, if you don't go the medical route, then you're fine. You're like, no, there will always be adjustment, but yeah. So those experiences that you talk about, you know, we have this big blind spot, la-di-da-di-da, oh, the birth doesn't really matter, as a culture, without saying, oh no, that matters more than anything. As you go forward in your life, you have to figure that out, because that's like your own personal warrior's or hero's journey.
Yeah. What a good way to put it.
Yeah. Yeah. It has those elements of how do you deal with authority? How do you deal with adversity? How do you accept support? How do you, you know, all of those things. Just like when Joseph Campbell used to talk about myths, or Jean Shinoda Bolen, or Claudia Pincola Estes, when they talk about stories and myths and how they pertain to our personal psyches, your birth stories in that same category.
Yeah. So, yeah. So birth matters is what you're saying. Yeah.
It matters. And not to everybody, because I want to also make that exception. Yeah. Some people's like, birth is what I got to do to get the baby. So it's going to be unpleasant. I'm not going to like it, but it's what I got to do to get the baby. And these people kind of, they just party on, you know, they just soldier.
And that's fine. That's awesome.
Exactly.
That's totally cool.
Yeah.
You know, and it's the same way with, you know, like moms who, for example, you know, have a cesarean, and, you know, 9 out of 10 moms are totally fine with it. And then there's the one mom who's not. And the thing is, this system has to accommodate all of those people. It's not okay to just accommodate the majority, you know, and then expect everyone else to fall into the same line as the majority, when, you know, that completely is leaving people with giant gaps in their, you know, in their mental health and in their physical health and their relationships and their, you know, their journeys into motherhood and everything else.
Yeah.
Hey, Amy, we are at 36 minutes right now. So I think we probably want to wrap up.
Sure.
I was curious, what was the response like to your article? Did you hear anything really interesting or new, or?
I had people who responded who said, I wish I would have known this last week. I had several of those, several people who
I saw one of those.
Now I'm going to know what to say the next time. And like I said, I sat with this for a few years.
Yeah. This article was a long time coming for you, wasn't it?
Yeah, it really was. It was not a knee-jerk thing. And going to births and saying, what would I do in this situation? And what do care providers want?
Yeah.
Too. Yeah. And what do they want? How do they want to be treated? And like you made the point very well about how they want to be treated. They don't want to have all this bad stuff assumed about them, but just, oh, I'm just not paying attention. So it's a much better assumption to go into it with, rather at the beginning until proven otherwise.
Yeah. Well, okay. So your website is Doulaing the Doula. You have more than one website.
But that's the one that Doula is my blog. And then my personal website is AmyGilliland.com. Okay. And that's got all my workshops on it and downloadable PDFs and all kinds of stuff like that.
And you have some awesome resources. I've checked them out. And Amy's not paying me to plug her either. No. I just really like sharing information that works.
And my doula training workshops are on doulaworkshop.com. Yeah. That's my training site. Yeah.
Okay. I'll put that down here too.
Sure.
And then just by coincidence, one of the next articles that I have coming out on Birth Monopoly is actually a letter to a doctor about basically what we've been talking about. So I don't know how many women have contacted me over the last couple of years, you know, to say, I don't know what to do. I was completely traumatized by the forced vaginal exam, you know, forced manual placental removal without, you know, without permission, or, you know, whatever the case may be, the stripping of the membranes without notification or permission. And so finally, this woman contacted me about one of these situations, and I finally just said, good Lord, I'm just going to write a freaking letter to this doctor, because I'm so sick of hearing these stories and then knowing that the doctors are almost never getting the feedback about it.
Yeah.
So I'll be publishing that letter pretty soon, along with some downloadable copies available for people to take and use themselves. So that's, you know, just another little resource for people.
Yeah.
Well, thank you, Amy. Sure. It was really nice to talk to you. I think this is the longest we've ever talked to each other.
Yeah.
On video.
I don't think it's going to be the last time.
No, I don't think so either. Well, thanks again.
Thanks.
All right.
For having me.
Cheers. Bye.
Bye.